Good morning, everyone around the world. I want to thank Robbie, Julie, and Lee for inviting me to interrupt your Saturday morning. I especially want to thank the Aplastic Anemia MDS International Foundation for its grant support, which came to me at a very pivotal time early in my career. And I want to thank whoever gave me this topic of what caused my bone marrow failure disease, acquired versus genetic, and allotted me 30 minutes to really cover everything about bone marrow failure. If we can have the next picture, please. Okay, so in my 30 minutes discussion this morning, I will try to keep you awake and introduce you to the area of hematopoiesis, which is the process by which blood cells are produced, to give a very general approach to bone marrow failure, a general approach to the different types of bone marrow failure, how we can sort of zoom in, so to speak, in gaining insights into a variety of bone marrow failure syndromes and diseases from genetically defined disorders. And then lastly, to conclude with the importance of research, clinical research, into developing new therapies. Next PDF. So blood cell production is a prodigious degree of constant production, proliferation, and differentiation of cells within the bone marrow, which is located in your bones. As one gets older, the amount of bone marrow that's in the body recedes, so that in an adult it's typically present in the hip bones. In a younger person, it's in the long bones and in the spinal, in the vertebra. So blood cell production is a tremendous amount of cell proliferation each day. There's over 200 billion red blood cells, almost 1 trillion platelets, and almost 1 trillion neutrophils that are produced per day. So this is a lot of cell turnover. And fortunately, most individuals go through their 70 without problems in their hematopoiesis and the production. And this is through a tightly regulated process of proliferation differentiation. If you look on the right side of the screen, I don't know if you can see my arrow. In the beginning is the hematopoietic or blood stem cell. And then through a series of cell divisions with differentiation, it becomes fully differentiated blood cells that we know as either lymphoid cells, which we won't talk about much today, which are T cells and B cells. T cells coordinate the immune response. B cells are the important blood cells that make antibodies. But what we're most interested in individuals with bone marrow failure is the non-lymphoid compartment, the production of red blood cells, the production of platelets, the production of neutrophils or monocytes that become macrophages, and we're sort of less concerned about basophils and eosinophils. So there's a tremendous amount of blood cell production that occurs every second of our lives. It's controlled by about 6 blood growth factors. Next picture, please. So bone marrow failure is the inability to produce sufficient a number of blood cells. It may be lineage specific or it may be pancytopenic. Lineage specific refers to either red blood cells and or white blood cells, primarily neutrophils, and or platelets, which are acellular fragments that clog up, prevent bleeding. And in the picture on the left here, you see is a normal-ish bone marrow in an adult. These are fat cells, and you can see here cellular types of cells of different sizes and shapes. And in the case of a bone marrow failure, what you basically are left is with fat cells and very, very few blood cells. Most of them, in the case of aplastic anemia, are lymphocytes that exist. Next page, please. So the types of bone marrow failure can be considered either as inherited or acquired. The inherited forms of bone marrow failure are typically found more in the pediatric population. not just under 18, but really under the age of 6. It's usually genetically defined. These are a growing list of genetically defined disorders that each one is rare, but together probably represents about 1 in 30,000 births. Interestingly, and obviously of concern to both the families and the patients, as well as the physicians that care for these individuals, is the issue that they often evolve into a myeloid neoplasia, whether it's myelodysplastic syndrome or acute myeloid leukemia. Acquired bone marrow failure syndromes typically are found more often in adults than in children. It's not so much genetic, but rather environmental exposure to viruses, drugs, chemicals. The incidence of acquired bone marrow failure syndromes in adults can be either rare or infrequent, with the most common form of bone marrow failure being myelodysplastic syndrome, which accounts for about somewhere between 12 to 20,000 cases in the United States each year. And what bone marrow failure involves are biological processes that really, whether it's inherited or acquired, involve 3 factors. One is the host or the individual. The other is the agent that the individual is exposed to, or the gene that the individual inherits. And then these interaction is modified by what a person eats or is exposed to, either by infection, drug, or chemical. Next page, please. And in the case of the inherited bone marrow failure syndromes, in this case, Fanconi anemia or dyskeratosis congenita, what you see is not just the blood being involved, but you also see findings in other organ systems. And so that really helps to direct our attention to whether somebody has an acquired bone marrow failure syndrome. And I'm not going to go through this list, but these things typically involve skin, size, skeleton, internal organs. Next page, please. So the approach for the diagnosis and classification of bone marrow failure follows a routine, which can be quite complicated. And it's of absolute importance clinically and for excellent outcome for the individual that an accurate diagnosis be made as efficiently as possible. And in the evaluation of bone marrow failure, which is typically performed by a specialist in the field of hematology oncology, it's of great value to take a very careful history from the individual as to his or her past medical history, recent complaints, and focus in on exposures, whether it's drug, occupational, travel, as well as to take a history from the individual about anyone affected in the family with deficiencies of blood cell production, or even to ascertain whether there's history of liver or lung fibrosis. And these will provide important clues as to whether this is inherited or acquired, acute, meaning new onset, or a chronic problem that has been around for more than several months. And then to do a physical examination, looking for some of the clues as to whether a syndrome such as Fanconi anemia or dyskeratosis congenita is present or not. From that history and physical, which are absolutely the bedrock of analysis, we then proceed to do the first tier of laboratory studies, which starts with the complete blood count with differential, evaluation of early cells being produced, such as reticulocytes, to do a screen of kidney, liver, and metabolic nutritional values, particularly focusing on vitamin B and 12 and folate. And then, depending upon what the picture emerges, one then decides to go and do a second tier of diagnostics, which rest on the bone marrow, because that is where the site of blood cells are produced. And one does an aspirate, and what is as important or more important is a biopsy, so one can identify the degree of cellularity that exists in the bone marrow, to look at any evidence of infiltration by either large macrophages or by cancerous cells, to send material from the bone marrow aspirate off to grow for what we call cytogenetics, to look at the chromosome pattern, to send blood cells off either from the peripheral blood or from the bone marrow. It can be done by peripheral blood for what we call immunophenotyping, as well as to look for special diagnostic values that would suggest something called paroxysmal nocturnal hemoglobinuria, or PNH. And this second tier of evaluation, what I think is becoming the standard operating procedure, is really to take advantage of what we call next-gen sequencing and the availability of robust panels to look at several hundred genes or more that have been associated with one of the different types of bone marrow failure syndromes. Having gotten this information, we will often consult specialists to make that accurate diagnosis. A critical individual is the hematopathologist, who studies the blood cells in the bone marrow. We will often consult a geneticist, genetics counselor, to take an even more extensive history. And then, depending upon what else is uncovered during the history, physical, and laboratory workup, specialists in either immunology, infectious disease, endocrinology, gastroenterology. And then with all this information, to synthesize the data and to see whether there is a specific diagnosis that we can make involving either an infectious inflammatory process, which would be like a secondary bone marrow failure, or acquired idiopathic aplastic anemia, or an inherited bone marrow failure syndrome, or whether it's myelodysplastic syndrome or something else. Next slide, page. Next. So among the acquired forms of bone marrow failure, drugs exposure, chemical exposure, radiation injury, infection, whether it's viral, fungal, or atypical mycobacteria. And then we get into other entities such as aplastic anemia, which Dr. Hanna will be speaking about shortly, myelodysplastic syndromes, which Dr. Caraway will be talking about shortly. And I think the next speaker, Dr. Majewski, will be talking about paroxysmal nocturnal hemoglobinuria. And then another condition, which we're not going to have anyone discuss, but it is either primary or secondary myelofibrosis, which is a myeloproliferative syndrome or neoplasm. And while I said that acquired forms of bone marrow failure typically occur in adults, they can also occur in kids. Next slide, please. The inherited forms of bone marrow failure, which is an area that I'm particularly interested in, is a growing list of syndromes and genetic entities that are individually rare, maybe occurring 1 in 100,000 or so births each year. And they go by sometimes odd names of the individual that first described them: Fanconi anemia, Diamond-Blackfan anemia, Schwachman-Diamond syndrome, dyskeratosis congenita, severe congenital neutropenia, a mouthful, congenital amegakaryocytic thrombocytopenia. And what's being more and more appreciated is that there are genes that are recurrently mutated that are associated with hematologic malignancies, primarily myelodysplastic syndrome and acute myeloid leukemia. And they go under the name of hereditary hematologic malignancies. And some of those genes have been identified as being GATA2 and RUNX1 and KRD26 or DDX41. And so inherited forms of bone marrow failure. If we can just back up for 1 second. Inherited forms of bone marrow failure syndromes, which typically are found in kids, but they can also occur in adults. And as my colleague, Dr. Majewski, identified, in one case, DDX41 may not arise until somebody's in their 6th or 7th decade of life. Next. So how does one study rare diseases, such as the inherited bone marrow failure syndromes, which I would suggest can provide insights into the more common bone marrow failure syndromes, such as myelodysplastic syndromes. And so these rare diseases we often talk about in medicine are zebras. So when you hear hoofbeats, you typically think of a horse and not a zebra. But when you go to a specialist, then that individual starts to think of these rare entities. And so we've been using zebrafish and mice to study some of these rare disorders. So we approach clinically an individual. We make observations about their history and physical. We get laboratory data. We form hypothesis, and we design experiments with the idea of trying to understand why people get bone marrow failure. So we gain new information, and this new information is critical in order to translate that into clinically important means of either being able to diagnose the individual more efficiently, identify individuals at greater risk or less risk for developing complications such as a malignancy. And then what we'd like to do is obviously try to develop a better therapy than the therapies that we have now. Next one. So the inherited bone marrow failure syndromes are experiments of nature. They give us insights into normal as well as disease blood cell production. And this is a topic I could talk about for hours, but I only think I have about 10 minutes left. These syndromes are called Fanconi anemia, severe congenital neutropenia, Schwachman-Diamond syndrome, Diamond-Blackfan anemia, congenital amegakaryocytic thrombocytopenia. I just like to say that word. Dyskeratosis congenita. The defects in the blood cell system may either be pancytopenic, involving all 3 cell lines, or they may be very specific to neutrophils, which we call polys, or red cells. And as you can see here, the lifetime risk may be as high as 30 to 40% in some of these inherited bone marrow failure syndromes for developing leukemia. And some of these syndromes are also associated with solid tumor development, particularly epithelial cancers. So it's really critical to make a diagnosis as accurate as possible, which means genetically defined, so as to provide the state-of-the-art surveillance and to catch things before they become more malignant. And what's interesting is that these syndromes, which we defined initially clinically, have turned out to be defined as well through genetic variants, and that these genetic variants will affect a specific pathway in a cell's process, whether it's DNA repair in the case of Fanconi anemia, or protein synthesis in the case of Schwachman-Diamond or Diamond-Blackfan anemia, or telomeres, which are the ends of chromosomes in the case of dyskeratosis congenita. Next, please. Okay. And even though one may have a genetically defined disease, we're still trying to figure out that what's the relationship between the genotype, the gene mutation, and the phenotype, which is the appearance. So just because you're born with a genetic disease such as Fanconi anemia does not mean that everyone's going to have the same phenotype. Some people will develop bone marrow failure. Others may develop myelodysplastic syndrome. Some may be on short. Others may be of normal size. Some may present within the first couple of years of life. Others may not have bone marrow failure until early young adulthood. So there are what we call deterministic factors, specific instructions, such as the gene itself, and then there are stochastic or probabilistic factors. So not everybody gets the same disease, and not everybody gets the same, if you will, severity of the disease, which we call penetrance. And there are factors that we are beginning to understand more and more that modify the phenotype. We call this either epigenetics, where you have a sort of chemical modification of genes. There's the environment, whether one is exposed to a particular virus or chemical or drug. There's something called epistasis, which is interaction of one gene with other genes. And what is of growing interest is sort of the role of the microbiome, the bacteria, the role of the immune system in contributing to the disease process. Next, please. So just to sort of wrap up and focus on two areas that we're particularly interested in, the inherited neutropenias and how we can learn from them to apply insights into normal as well as diseased blood cell production. We've been studying something called severe congenital neutropenia, which was described originally by a surgeon doctor in Sweden, Dr. Kosman. And so some references you'll see in the literature talks about Kosman syndrome. It's a life-threatening neutropenia that typically occurs within the first couple of months of life. And when we take a look at the bone marrow, as shown on the picture right here on the right side, one can appreciate that there are an accumulation of what we call promyelocytes. I don't know if you get to see my arrow or not. And this is an arrest in the growth and differentiation of blood cells. The treatment for this disease in almost all individuals is the growth factor called G-CSF or filgrastim. And the genetics of this disease is interesting and is typically involves the mutation in an enzyme called elaine, which is involved in host defense. Next slide. Next page. And what's interesting is that this is the gene elaine, and these are the different types of mutations, about 100 or so. And some of these mutations are found both in individuals with chronic neutropenia or a very related disorder called cyclic neutropenia, where the white count, the neutrophil count, will vary every 21 days or so, where it bottoms out, and during which time individuals will develop fevers, mouth sores. So this is an example of, the genotype-phenotype dilemma, that just because there's a mutation that's been identified doesn't mean that we fully understand what type of disease will go on and whether it will be severe or mild or moderate. We're trying to understand what are the factors that modify this. Next picture. And in particular, what we're interested in is what we call the signaling of the G-CSF receptor, which is shown in this structure here, and that the receptor recognizes the hormone G-CSF, and then that information is transmitted inside the cell, kind of like a signal within a TV antenna that goes to your television box. That's the days before cable. And that information is relayed into the interior of the cell through a bunch of enzymes known as Lin or Jack. And that these enzymes set off a bunch of chemical reactions that lead to differences in gene expression that leads to neutrophil production. And shortly after the introduction of G-CSF for the treatment of severe congenital neutropenia, which was clearly a game changer in the quality of life of individuals, and Stacy Arnold will be talking a little bit later on about quality of life in individuals with bone marrow failure. What was clearly recognized was that a small subset of patients, and now a bigger subset of patients, develop myeloid neoplasia, either myelodysplastic syndrome or acute myeloid leukemia. And those individuals developed a mutation in the G-CSF receptor, cutting it off at between the first and second Y, which stands for tyrosine. So this is an example of how inherited mutation in elaine will cause a disease called severe congenital neutropenia. Most individuals will have a wonderful response to G-CSF, but in a subset of patients, there will be an acquired mutation in the G-CSF receptor, and that is highly correlated with transformation of the disease to myeloid neoplasm. Next picture, please. And what we see is something called what I call game of clones, where in this case, this is an example of an individual who had not just one, but 4 mutations of the G-CSF receptor that arose within several years of treatment with G-CSF. These clones disappeared, maybe because of immune surveillance, or maybe they just didn't have that extra oomph provided by additional mutations in genes. And unfortunately for this individual, this clone of cells persisted, acquired additional hits, genetic mutations involving yet another mutation of the G-CSF receptor, a chromosome abnormality called trisomy 21. And so you have a competition of clones, and unfortunately this clone of cell dominated, acquired more genetic hits, and unfortunately for the individual became leukemic. Next picture. Next, okay. And so what we'd like to do is to, and some of you who have myelodysplastic syndrome have been told by your physician that you have a particular score, and this will indicate the severity of the disease. Well, what we'd like to do is to do something called liquid biopsies. Instead of taking bone marrow aspirates, what we like to take is your peripheral blood and measure the amount of mutated G-CSF receptor and calculate if and when there will be a transformation event. And the idea is to intervene earlier before the disease becomes truly malignant. And so this is something that we're working on, which is to develop an even greater individualized prognostic scoring system based upon a liquid biopsy. Next picture. So I want to sort of give a couple slides to discuss going from zebras to zebrafish. And in this case, we're talking about Schwachman-Diamond syndrome, which is characterized by neutropenia in the vast majority of individuals, about 90%. But the individuals can also have waxing and waning of a shortage of blood cells, anemia, or thrombocytopenia, platelets. They also have malabsorption due to their pancreas not working well. They have skeletal anomalies, whether it's an extra digit or whether it's a small rib cage. And this syndrome, too, is associated with an increased risk of developing myeloid malignancy. The gene that's involved in this is called SBDS, for Schwachman-Diamond syndrome. 90% of individuals with this syndrome have this genetic mutation. And it's a group, it belongs to a group of disorders that we also see in other forms of bone marrow failure, such as Diamond-Blackfan anemia, or in the adult disease called deletion 5q syndrome, where you have a mutation in a component of the ribosome, which is the machine to make proteins. Next picture. Next. So what we decided some time ago was to try to model this disease in zebrafish. Why do we turn to zebrafish? Well, the individuals with Schwachman-Diamond syndrome are rare, so there's not many patients to study. One can try to make a mouse, but the mice do not survive beyond the first trimester. When we looked at the gene, the coding material, and the protein, the building blocks that are encoded by the gene, there's about 90% similarity, believe it or not, between humans and fish. Fish also develop quickly within 96 hours, and the fish lays 100 eggs, so we can do what we call statistically significant studies. And so using a new technique called CRISPR genome editing, Dr. Oyerbida in my lab has created a Schwachman-Diamond fish. Next picture. Next. And so the fish are small, like we see in kids with Schwachman-Diamond syndrome. Here is a normal fish and a mutated fish at 15 days after fertilization. And by 35 days after fertilization, you can see that the brother and sister here, this fish is of normal size and the Schwachman-Diamond fish is much smaller. So they're small, like kids with Schwachman-Diamond syndrome. Next. Forward, please. And when we took a look at the number of neutrophils, we did this by marking the neutrophils and we counted the neutrophils. One can see as early as 5 days after fertilization, and certainly by 15 days of fertilization, a statistically significant decrease in the number of neutrophils. Next. When we looked at red blood cells, and here we stained the fish to stain for red blood cells, we saw no difference, which is basically what we see in kids with Schwachman-Diamond syndrome. Next. And when we stain for bone using a dye here, if you have very good eyesight, you can see that the spine is moth-eaten and that there's curvature of the spine. So there's obviously abnormalities in bone formation. Next. So what we like to do, I think I spoke too fast, is to use the fish in order to understand the process by which Schwachman-Diamond syndrome evolves, to understand what's going on biochemically, and to interrogate the fish for genes that cooperate with the mutated Schwachman-Diamond gene, so as to identify which genes are the second or third hits, if you will, in the transformation. And then lastly, we want to use the fish as an experimental tool to develop better therapies. So the goal in the inherited bone marrow failure syndromes is to identify a malignant clone of cells before it becomes established, before the horse has left the barn, before the train has left the station. At that point, when somebody has developed myeloid neoplasia, the treatment is stem cell transplantation, which is both a costly as well as a somewhat painful and protracted hospitalization stay. And we like to, not everyone needs a transplant. We like to identify those at risk. We like to be able to develop chemopreventive means or molecular targeted therapy. And we can't do this in a rare disease. We have to rely upon what we call an animal model. And so we're working now with investigators around the world to develop therapies to modify Schwachman-Diamond syndrome and to prevent its transformation to leukemia. Next slide. So steps to healthier lives for those with bone marrow failure is one, got to make an accurate diagnosis. This often involves a team approach using state-of-the-art laboratory genetic testing to work with physician scientists and scientists to focus research on these entities and to understand what we call the pathophysiology, the disease process, to take the new information, to translate new knowledge into better means to monitor, to perform surveillance of the individual, and to develop state-of-the-art therapies, which again requires really referral to a center where there's specialists in the field of bone marrow failure. Because I think I've portrayed in the past 35 minutes or so that it's quite complex. You have inherited disorders, you have acquired disorders, that the, if you will, the laundry list of entities that cause either inherited or acquired disorders are quite lengthy and requires a team approach to making a diagnosis and then to treat. Then lastly, next slide, I want to obviously acknowledge the group of individuals and institutions that have funded our research. And I want to emphasize again that I received a grant as an assistant professor from the Aplastic Anemia MDS Foundation, which was very important. And thank the individuals in my group that dedicate their lives, their careers to studying bone marrow failure, and be happy to take any questions at this time. So thank you for getting up early on a Saturday morning and listening to me.
Thank you so much, Dr. Corey. We do have a few questions. Has there been any links found between aplastic anemia and a disease such as multiple sclerosis?
I'm not aware of any connection between multiple sclerosis and aplastic anemia. That doesn't mean aplastic anemia, as I'll defer to Dr. Hanna in his presentation, is an autoimmune disorder where an individual exposed to a virus or some agent with some genetic predisposition will unfortunately develop blood cells, both T cells and B cells, to attack the body and destroy the blood cells in the marrow. Multiple sclerosis is another example of an autoimmune disorder. Some autoimmune disorders do go hand in hand with bone marrow failure, such as lupus, for instance, where you have antibodies against blood cells. But I'm not aware of multiple sclerosis association with aplastic anemia. Now, some of the drugs that people are being treated with multiple sclerosis can be toxic to the marrow, but I'm not aware of any direct relationship between multiple sclerosis, which is an immune attack against the myelin sheaths of your nerves, with an immune attack against your blood cells.
Thank you. Could a family member's diagnosis impact the possibility that their children will also develop aplastic anemia?
So the term aplastic anemia is sort of an umbrella term. And oftentimes we talk about idiopathic aplastic anemia. It's very important during that evaluation of an individual with bone marrow failure, with pancytopenia, that diagnostic tests be performed to rule out or to rule in the inherited bone marrow failure syndromes, such as Fanconi anemia or dyskeratosis congenita. In those cases, those are in fact disorders that in some cases may be associated with decreased fertility, may not be, but they are transmitted either in what we call an autosomal dominant, where you just need one abnormal gene from one parent, or autosomal recessive, where you need to have both the mother and the father have a variant in a gene that's associated with the disorder, or in some cases they're also X-linked, which means typically boys are affected. So aplastic anemia that's idiopathic is not typically inherited, but the conditions that result in inherited bone marrow failure syndromes, such as Fanconi anemia, dyskeratosis congenita, are indeed transmissible from parent to child.
Thank you. Is it possible to be predisposed to aplastic anemia or any other bone marrow failure disease and have it suddenly impact the patient?
Yes. So those disorders that are inherited may be what we call latent for decades, as in the case of RUNX1, which is a gene that's involved in platelet development. So, or ANKRD26, which is another gene that's involved in platelet development, or DDX41 that my colleague, Dr. Majewski, described. So individuals, we all carry genes that vary between individuals. So we all, if you have some sort of genetic baggage. Some of us learn about that through a diagnosis. Some of us may not know about it until we get diagnosed with that disorder. So until the day happens when we can do a genetic screen shortly at birth, most of us are just waiting for the genes to express themselves. And as I said, just because you have a variant, a mutation in a gene that may be associated with disease, that may not mean that you're going to get severe disease. You may get mild disease, or you may really have no evidence of disease at all. So to answer your question about, a predisposition, yes, we're learning that there are more and more genes that predispose an individual. There are what we call HLA types and genome-wide association studies to suggest that there are predispositions to infection or to immune reactions. So this is part of, our growing revolution in medicine that's directed by gene discovery. So yes, that's possible. And the cost of doing whole exome sequencing which is where you take all the genes that express a protein and sequence them, and looking at a variant is becoming more and more realistic. It costs a couple $1,000s, but the problem is we're getting lots of information. So there's 3 billion letters that code for DNA in each one of us. And each one of us will vary from our brother or sister by like 1 million. And so some of those changes in the primary code may be linked to disease. They may be called a variant of pathogenic significance, or it may be a variant that hasn't been attributed to disease, and we're getting more and more of that information as gene sequencing is being done. So we call that a variant of unknown significance. So things have gotten simple, and now they're getting more complicated as far as the diagnosis of bone marrow failure and predisposition. But we all carry something.
Thank you so much, Dr. Corey, for sharing your time and your expertise with all of us today. If you'd like to watch this conference session at a later time, it will be available on our website within 2 to 3 business days. If we were not able to get to your question today, please do send it to us in 3 ways. Send an email to help@aamds.org. Call our helpline at 800-747-2820, extension 2, or submit your question on our Facebook page. This conference session is going to end. To rejoin the next session, which will start in approximately 10 minutes, please use the same Zoom link or call-in number that you use to access this session. It's also available in your conference registration email and your reminder email. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. The Aplastic Anemia and MDS International Foundation Medical Advisory Board and team are here to help you and your family, as we have done for the past 36 years. This concludes our session. Thank you, Dr. Corey, for joining us today.
Thank you. Have a great weekend. Have a great rest of the symposium.
Thank you.